just to start, what is next generation sequencing and how has it changed the field for treating GI cancers?
Yeah, I mean, in very simple terms, next generation sequencing, it's interesting because it's not the next generation anymore. It's the generation we've been living with for a while. It essentially, we started with very limited sequencing using, hotspots, using limited panels, 8 genes, 16 genes. And then we got to this next generation sequencing that increased quite a bit the level of sensitivity and detection rate, a whole array of genes, depending on which one you look at, 200, 300, 600, etc. Many of them are technically useless because you can't target them. But with time, we're figuring out that a lot of the quote unquote useless are actually useful as we get drugs that target them. So next generation sequencing, essentially platforms right now are multiple. Many of them are institutional, like Memorial Sloan, MD Anderson. We have our own at Mayo Clinic. But the most successful ones are actually the ones that are run by for-profit companies. Not to name any, but there are a number of them in the market that are available, and we use quite a bit of few. They essentially tell you about the DNA. Some actually include RNA and even immunohistochemistry. Those that include RNA are preferred, especially when we're looking for fusions versus the ones that just do DNA. And the RNA is increases the level of sensitivity for these fusions, which are important for some of the rare targets like NTRK fusions, or less rare in some cancers like cholangiocarcinoma for FGFR fusions. And IHC, is becoming more and more obsolete, but still useful. For MSI, it's very useful. For HER2, there's occasionally some level of discrepancy. I'd say, there's a very small percent of patients where you may not see the amplification, but you see the IHC positive. I mean, I think that's becoming less and less relevant. The other value to this next generation sequencing is essentially depicting tumor mutational burden, which, as you know, now we have an approval for intermediate to high tumor mutational burden tumors with pembrolizumab. And so we rely now more and more on these tests, on this next generation sequencing testing, to include more options, including targeted and immune therapeutics. But it also, frankly, it also helps with choice of chemotherapy. We always talk about next generation sequencing as a key component of how we pick a targeted strategy or an immune therapy. But the presence of ATM mutation, for example, in addition to have some studies that are specifically targeting it, or ATR, we actually know that ATM alterations increase the level of sensitivity to platinums and to topoisomerase inhibitor like irinotecan. That's a plus. In pancreas cancer, up to 1 out of every 5 patients may have an ATM alteration, and so that helps you with directing the treatment choice. BRCA. So BRCA is not just a germline alteration, and we do see those, of course, in 2 to 3% of patients. But in another 2 to 3%, it's a somatic alteration. And the presence of BRCA also leads to platinums, to topoisomerase inhibitors, but also to PARP inhibitors. And, you could say, well, I'm going to just test folks, for germline alterations, and that's how I'm going to determine it. You're going to miss half of the patients who actually do have a BRCA overall, meaning 2 to 3% somatic, 2 to 3% germline, and they seem to respond very similarly to treatment. So all these different alterations are important for chemotherapy choice, for some, for targeted strategies, for immune therapy, and more understanding about those. And we have the rare, the less rare, the less common, the common, and the very common in that range in terms of alterations. Across malignancies, but in pancreas, in GI cancers, we're seeing quite a bit of activity. Remember, GI cancers is 20% of all cancers. That's a lot of cancers we cover.
And in your conversation with the journal Oncology, you mentioned that next generation sequencing is a right, not a privilege. Or that's how you feel.
Yes.
Why do you think that, and what brought you to this conclusion?
I think, and I understand from the societal standpoint, some people may argue, I mean, why do you want to do this? Let's do it targeted. You know, let's say in colon cancer, let's pick KRAS, BRAF, HER2, and MSI high, and we'll worry about the rest later, if we ever worry about it. Well, I would argue first that when you look at the cost of doing individual alterations, it's actually ends up being more expensive, just from the cost value. It ends up being more expensive than doing the whole panel. So cost argument, I don't think it holds quite a bit, at least for colon. Now, you come to the argument for pancreas and others. You say, well, you know, in pancreas, it's very rare to find a target. So why do you want to spend that much of an effort to actually find these rare targets? And I will do it when I think I need it, meaning that, you know, I have a patient who comes in, I know what I'm going to treat them in first line, but then I'll decide what to do in later lines. Well, here's an argument against that. BRCA present in 2 to 3% of these patients. ATM, that's present in many more. Those do predict for an improved outcome with platinums and with topoisomerase. So it has relevance. It's not just the fact that we're picking those up for, say, the PARP inhibitor. But in addition to this, if your choice, which is for most patients, my choice is gemcitabine, nab-paclitaxel in the first line, but I would be swayed in a different direction if I knew the patient had an ATM or a BRCA. Now, that's for the common or less common. But how about the rare? Because I think the biggest argument against doing it to depict the rare is, well, it's rare. Well, let me give you, I mean, simple math, frankly, would help with that. If you have a target like NTRK fusion, let's say, which is 1 in 500 patients, it's rare. But, I mean, you have to treat one of those patients when you find the NTRK fusion to know that although it's rare, but if you find it and you hit it with an NTRK inhibitor, there are 2 on the market right now, you will have a response that's very similar to what you see with MSI high and PD-1 inhibitors. Same, and I'm taking pancreas cancer because that's an extreme example. Same for MSI high. In pancreas cancer, 0.5 to 0.7% of patients will have MSI high. If you've ever treated, and I have with both NTRK fusions and MSI high, I've treated patients with a specific target. So with MSI high, I've treated multiple patients actually, but I can give you one perfect example. A patient who failed chemotherapy ended up being found to have MSI high. That's 5 years ago. Went on pembrolizumab, had a fantastic response, had to stop the treatment after 9 months of therapy because of toxicity. Yet, 5 years after, she remains in CR. It's a cure. When you see those, you understand the value of testing. Now, again, you say, well, you know, is it really worth it for 0.5 to 0.7%? Well, with simple math and statistical understanding of, you know, how things work, if you don't consistently test every single patient, then the 0.5% becomes 0.05% and becomes 1 in 10,000, becomes eventually 1 in 100,000, 1 in a million. So your chances of finding the needle in a haystack becomes incredibly dismal. So the reason why I think it's a right and not a privilege anymore, I think it should be applicable to everyone, not just whomever can pay for it, or if you're lucky enough to have a relationship with a company and the company will cover it. We actually need to make it available for every single patient to make sure that If it's rare, we're going to find it at a consistent level. If it's common, great. We're going to find it. We're going to find it even better. And if it's less common, again, by just consistently testing, the less common in our clinics becomes enriched and becomes more common. So for these reasons, I think every single patient has the right to get their next generation sequencing test to cover all bases, including their therapeutic bases. Shouldn't be a privilege anymore.
And later on in this same conversation, you said that the field was 2 to 3 decades behind other cancers in regard to biologic and immune-based therapy. What was holding back?
Was,
What's that?
was behind.
Right. So what was holding back the field from advancing previously, and what changed to make you
Yeah,
confident the field will be ahead of the curve in 3 to
yeah,
5 years?
yeah. No, that's a fair question. So why were we behind? Well, the reason why we were behind is because we spent so much time arguing against widespread testing. And we were focused so much on the question of FOLFOX, colon cancer, FOLFOX versus FOLFIRI, which one comes first? And then we wasted another 5 years just talking about, whether we should do bevacizumab or an EGFR inhibitor, whether right side or left side eventually. I mean, this is what we spend all this time discussing, rather than focusing on the targets of value like BRAF, which now we have, a combo that is transforming how we care for this disease, and it's moving to first line testing. MSI high, we started in later lines, and we had this argument, well, should we use it in first line? And ended up, in first line, and makes a dramatic shift in 20 to 30% of the patients, where you may never need chemotherapy for the rest of your lifetime. You're cured of your cancer if you had that MSI high. So we spent 20 to 30 years arguing about things don't make any sense, although they made some relative sense. I shouldn't poo-poo this completely, but they made some relative sense because they were the reality of our days. But I want to give you an example. In the mid-2000s, there was a study that was looking at HER2 target strategies in colorectal cancer, okay? That's HER2 in colon cancer. It was at a level of 5 to 7% by IHC. That's at least how it was depicted. The study couldn't accrue well because we considered, or the authors of the study then considered that this was a rare target, 5 to 7%. Think about what we're talking about today. When we talk about a rare target, it's 1 in 500, 1 in 1,000. 5 to 7% is actually a common target. So that study couldn't accrue with trastuzumab. It was deemed that this study is not feasible and it's unlikely to make a difference. Now, zip through, a few years later, we have a study from Italy, Heracles, that shows that if you target the subgroup of patients with HER2 target strategies with lapatinib, which is not really a good HER2 target strategy, but it was what was available to them, plus trastuzumab, that you actually have a 30% response rate, and some of these responses last forever. And then continue to zip through. Today, we're looking at an agent called tucatinib plus trastuzumab. Tucatinib is a more HER2 specific target strategy, really safe. In breast cancer now, it's approved in refractory trastuzumab. In colon cancer, we presented our data at ESMO, and we hope to present an update on a much larger cohort later this year, early next year. And then we have the DS1801, the ADC, the antibody drug conjugate that showed 40, 50% response rate. I mean, it comes at an expense of toxicity, even in patients who failed other HER2 target strategies. I mean, look where we're at today. 15 years ago, we're arguing against HER2 as a target. Today, HER2 is one of the most exciting targets. With BRAF mutations, same thing. I mean, we were, for the longest time, finding ways about, do we give EGFR or not? Does it make sense? No, let's give EGFR because crystal studies suggest that it may actually have value. But then other studies suggest that it has zero value. Well, it turns out it actually has zero value if you give it without a RAF inhibitor. Before Scott Coppett started doing a lot of his work in the lab and pushing that agenda forward, ultimately, leading to that Beacon trial that led to encorafenib plus binimetinib, and the BRAF mutated, those patients do horribly, and published his paper in New England Journal of Medicine and really transformed the way we treat those patients. And now it's moving to first line. But we spend so much time. I mean, look at lung, look at breast. The common cancers and GI cancers overall are some of the most common cancers, but colorectal cancer specifically is one of the four most common cancers. Whereby in lung and in breast and even in, you can argue, in prostate, they've moved that field quite fastly forward because of forward thinking. Our thinking in colorectal has stalled for the longest time because of just, I think, again, mostly focusing on questions that did make some sense, but didn't really move the field forward. And today we're just catching up fast, and not just in colon, in every GI malignancies, with immune therapy, with target therapies, even with a better understanding where and when to use chemotherapy.
And so you mentioned a lot, like 10, 15 years ago, the research that was published that helped, that impacted the field progressing. How has some of the recent research published from the last year or two changed the practice?
Yeah, no, I think a lot of it is really stemming out from 20, 30 years of work in some of the best labs, understanding what drives cancer, what drives aggression, the immune therapy, understanding of the role of immune therapy in what setting, etc. And that continues to happen. How do we define further, our understanding? So let's take examples. Today we have an agent in cholangiocarcinoma called pemigatinib that seems to work in about 30 to 40% of patients with FGFR2 fusions. Okay, that's about 10 to 15% of all intrahepatic cholangiocarcinomas. Some of these patients do fantastic and are on the drug for a long, long time. Others don't respond, and some respond for a little while and don't. So a lot of the work that is being done, a lot of some of it is also being done right now at the Mayo Clinic, is to try to understand the mechanisms of resistance and future combinations with these FGFR inhibitors to address the question of why some patients don't have durable responses and why some do not respond, and can we, add target strategies to other pathways known of resistance, like YAP-directed, YAP-directed pathways that maybe target may reverse some of the resistance. So that's one example. Another example, say with PARP inhibitors and pancreas cancer, they only work in 15 to 20% of the patients. I mean, in ovarian cancer, they work in 50% of the patients. So why the discrepancy? You have the same mutation driving an event, yet in one cancer, you get a fantastic response, and another cancer, you get an okay response at best. So trying to understand the mechanisms of resistance, and learning from other cancers as well, but also the specifics of pancreas cancer. It does appear that in pancreas cancer, a PARP inhibitor on its own is not going to hold a good response, and that you probably need to enhance it, whether you combine it with some rational and targeted therapeutic strategies with chemotherapies, such as nanoliposomal antican, for example, place it strategically along with that backbone, or combine it with other immune therapeutic agents. And some of the basic science and translational science work is focusing on that question. Then, understanding, for example, the recent approval of atezolizumab and bevacizumab in HCC came at the heels of failures of single-agent PD-1 inhibitors like nivolumab and pembrolizumab to enhance activity or to move the needle forward versus TKI or placebo, sorafenib or placebo. So the understanding came from essentially research that suggested that applying VEGF inhibitors essentially makes the immune milieu of HCC more favorable for PD-1 or PD-L1 inhibition. And so that translated into studies that essentially combine the two and have led the field forward. Now, that's not enough, right? I mean, because that essentially helps with only 30% of the patients. I mean, it helps with most patients a little bit, but only 20 to 30% a lot. And so trying to understand again why these other patients do not respond and how can we target them differently or enhance the advantages of what is actually some of the work that's being done in the lab. Finally, and there are a lot of different examples that we can go through. But finally, going back to biliary cancer, which we continue to find out how rich in mutations and amplifications and fusions and alterations this disease is. Finally, how to break down biliary cancer into all these different diseases and understanding the heterogeneity of sites is also transforming how we treat for this cancer. I mean, this is a cancer that 10 years ago, we barely had chemotherapy options for. The only study that came to us came from the UK, suggesting that if you add cisplatin to gemcitabine, you actually may move the needle a little bit forward. That was it. I mean, those patients had zero options. Today, we're talking about Bekaii-Saab, we're talking potentially about an IDH1 inhibitor that's on its way to the FDA. We're talking about MSI high and and immune therapy, but we're also talking about immune therapy and non-MSI high, looking at other reasons for patients to respond to those. And we're looking at HER2, we're looking at BRAF, we're looking at all these things. And a lot of it has been based on a basic understanding of the mutational landscape and how to best target these therapies. Same for colon, same for gastric, same for all these GI cancers we're doing. So it's an incredible time in cancer in general. It's an incredible time, but specifically in gastrointestinal cancers, where we've fallen so far behind, and now we're frankly being thrusted into the limelight. Finally, being able to say that we can move the needle forward in a very meaningful way across all these cancers that we treat.
And lastly, is there anything that I haven't asked you that you think is important to discuss regarding GI cancer or next generation sequencing?
Yes, I mean, just in summary, I think the future is really bright, but it's really focused on a clear understanding about how to take this mutational landscape that, or I should say, alterations, so genomic alteration, because it's not just mutations, it's amplifications, it's fusions. So how to take this genomic landscape and apply it to the clinic and apply it to research. To the clinic today, we have agents that are available to us that depend on the findings from these next generation sequencing assays, and then how they lead into targets that, as I said, rare, less common, or really rare. But it also helps advance the research mission. I mean, without actually a clear pathway moving forward about how to integrate these tests, these next generation sequence tests, not just into the clinic and how they apply immediately to clinical care, but how they actually help us stratify patients into various studies we have, because they depend on the presence of these alterations. Most of the studies we're taking on today do depend on the presence of these alterations. The one thing that's facilitating also our real-time access to a lot of these trials and being able to place patients into them is the wider availability of liquid biopsies. We just heard a couple of days ago about Guardant 360 having its test approved by the FDA. So now we don't just have to wait for tissue, but we can essentially, as we wait for tissue, because tissue is still the most established way to do it, similar to lung cancer and their depiction of EGFR alterations through liquid biopsies. Now we have a test that at least is approved by the FDA that we can use. Well, it wasn't just approved for GI malignancies, but since we're talking about GI malignancies, where I can find my BRAF mutation rather than wait 2 to 4 weeks for a tissue and then enroll the patients into a clinical trial, the Breakwater trial, say, that's now looking at first line. looking at HER2 amplifications. Look at MSI high. I mean, through liquid biopsies, you can depict MSI high if you don't have it on tissue for whatever reason. Very quickly would help us essentially establish that. So today we're transforming the practice, not only just having availability for next generation sequencing on tissue, but also be able to integrate liquid biopsies. Now, liquid biopsies also will have an impact about how we understand the clonal evolution of cancer. We can't, follow patients with tissue biopsy and put needles left and right into those patients, because one, we know that cancer is heterogeneous. So if you hit the liver lesion, it doesn't necessarily look like the lung lesion. The liquid biopsies will allow us to follow the evolutionary landscape of the various clones in cancer and emergence of new mutations, emergence of new alterations, or disappearing clones. Now, I'd say that this is not something that I would do in clinical practice, but this is something that I would do mostly on research. Ultimately, I suspect this will become a standard practice for us. So very exciting time. And it goes back to the point that I made initially. The next generation sequencing is not a privilege anymore. It should be a right. For every patient has the right to understand what's driving their tumors, and for us to understand how to best optimize their treatment options depends on the availability of the results of these tests.
Great. Well, thank you so much for your time and insight, Dr. Bekaii-Saab.
Okay.